Our first topic this morning is sleep issues and sleep management by Dr. Vaou. Dr. Vaou joined UT Health in San Antonio. She serves as the division chief of the Movement Disorder Center, which is now a designated Parkinson Foundation Comprehensive Care Center. Dr. Vaou is also the vice chair of faculty development and wellness in the Department of Neurology at UT Health San Antonio. Prior to that, she served as the director of the Movement Disorders and Deep Brain Stimulation Center at St. Elizabeth's Medical Center in Boston, Massachusetts. Her expertise in treating patients with Parkinson's disease, atypical Parkinson's, essential tremor, and other movement disorders. She is also a board-certified sleep specialist and treats sleep disorders in patients with movement disorders. Dr. Vaou's passion is deep brain stimulation and sleep disorders in Parkinson's disease. In addition to treating patients with movement disorders and Parkinson's, Dr. Vaou is the vice chair of faculty development at UT Health in San Antonio. Dr. Vaou participates in clinical research evaluating novel pharmacological agents and patient education in Parkinson's disease. She is very involved in raising awareness of early PD and DBS treatment and PD in women. She is also very passionate about genetic testing in people with Parkinson's disease, with a particular focus in the Hispanic population. I would like to welcome Dr. Vaou.
Good morning, everyone. Thank you so much. Thank you, Charlene, for your introduction, and thank you to the Parkinson's Association of Alberta for inviting me. This is a great pleasure to be here, and my goodness, such a great audience that we have. So before further ado, I'm going to get started. I'm going to share my screen. Again, if you have any questions, happy to answer them at the end. I will not be seeing, since I'm sharing my screen, anything in the chat until the end of my talk. So I'm just sharing here, and just one second. Okay, here we are. I hope you can see. Can you see my screen? I hope you can. Charlene, can you tell me?
Yes, we can see it. Thank you.
All right, wonderful. And I just want to make sure that I'm able to, this bar is not going away from here, but we're going to make it happen. There we go. All right. Okay. So let's talk a little bit. I know I only have a few, I could be talking about this for hours and hours, but I'm going to go quickly through all the sleep matters that patients with Parkinson's have. Just an overview: Parkinson's disease was first described in 1817 by James Parkinson, but right now we know so much more about Parkinson's, but he described it pretty well as well, including the sleep disorders. We now know that in 2030, it is projected that in the US we'll be having about 1,238,000 patients with Parkinson's, and that number is rising very fast. We all know that the Parkinson's disease, the pathology, is loss of dopamine in the substantia nigra. And in 1912, Frederick Louis discovered some inclusions inside the cells, which are composed of alpha-synuclein. This is what we call Lewy bodies. And this is the pathology of the disease. This is the staging of Parkinson's disease based on BRAC. It's a pathological staging. So what we see in the beginning, this first and second stage, it starts in what we call, this is the brain stem, down with the shaded area. And the pathology starts in that area, and then it gradually includes the rest of the brain as the disease progresses. And we do see that we start noticing sleep disorders in the initial stages, but also as the disease progresses. So more or less during the whole spectrum, we do see different types of sleep disorders. And of course, this is very individualized, as not one patient with Parkinson is the same. We all know about Parkinson's being something we see: motor symptoms, tremors, bradykinesia, rigidity. But that's just what we see. That's the tip of the iceberg, because underneath it, we have so many non-motor symptoms, including sleep. And these non-motor symptoms is really what is affecting the patient's quality of life. So in terms of sleep disorders, we do see anywhere between 66 to 9% of patients with Parkinson's do have sleep problems. And honestly, it's really a surprise to me when I see a patient in my office who says, "Oh, my sleep is wonderful. I sleep great. I have no problems or concerns." And that happens, but it's extremely rare. Patients have trouble with REM behavior disorder, with daytime sleepiness, with trouble falling asleep or staying asleep, what we call insomnia, restless leg syndrome, as well as periodic limb movements of sleep. And we'll go over each one of those. One thing I'd like also to mention, again, it is kind of a very big interest of mine, is the gender differences in terms of how the disease presents between men and women. We know that women present more with fatigue and pain, definitely more anxiety and depression, as well as the restless legs, whereas men present more with daytime sleepiness, more sexual problems or olfaction, do not have as many sleep problems, especially not as much insomnia as women. So there is definitely a discrepancy between genders. A few things on REM behavior disorder. I'm choosing to open my talk basically with this sleep disorder because it is it has a lot of implications. It is very common, and I would love to raise awareness to everyone about what REM behavior is and why do we treat. So what typically when for patients who don't have Parkinson's disease, the rest of the population, when we sleep and we dream and we're in our REM stage, our muscles are paralyzed. In patients with Parkinson's, that does not happen. The muscles have muscle tone is present. So they are able to use their muscles. So if they're dreaming of something, they're able to enact their dreams, whether that is just waving or talking or thrashing or walking. It really depends on the patient. It depends on the severity of their REM behavior disorder. And it could be anything. It could be punching, it could be walking, leaping out of bed. It really has no specifics of what this motor behavior will be during this REM phase. It's typically diagnosed over an overnight sleep study where we actually do see those behaviors happening in REM sleep, where patients or people dream, or just by history alone. Typically you don't have to always send someone for a sleep study to be able to diagnose it, because if someone has Parkinson's, they are actually telling you about these symptoms. There's also certain questionnaires that we go by. It's easy to diagnose clinically as well. It does happen to anywhere between 25 to 50% of patients, but it could also be higher than that. What we do know, what's very interesting, is that this behavior starts much earlier, before the diagnosis of Parkinson's. So now we're looking at this as being a prodromal biomarker or a symptom that perhaps we can diagnose someone with Parkinson's earlier. So this is why we're really having a lot of research being done in the recent years to see how can we use this disorder, this disease, or this symptom to be able to diagnose someone before the motor symptoms start, so as to perhaps intervene to delay the onset or delay the progression of the disease. It's also very important because it can lead to injuries to the patient or the bed partner. We have lacerations, fractures, dislocations multiple times once the patient has REM behavior disorder. So this is something to always keep in mind when we're thinking, should we and when we should treat REM behavior disorder. We do know that patients who have hallucinations and dementia have a risk factor of worse REM behavior disorder. Men may have higher risk of REM behavior disorder when they're on antidepressants. That increases the risk of REM behavior disorder. And this is the significance of what I was talking about, REM behavior disorder presenting early in the disease, before the diagnosis of disease. So this is a study that was done in 2013. And it was really, really significant. They looked at patients, 100 patients who had only REM behavior disorder, nothing else. They didn't have any cognitive problems, tremors, no diagnosis of Parkinson's. And they followed them over 15 years. This is the 15 years. And this is when these patients start having some neurological disorders towards some neurodegenerative disorder. And as they were following through the years, we looked at most patients converted into having some type of neurodegenerative disease. About 80%, 82% developed some disease over a mean of 12 years follow-up. 16 patients developed Parkinson's, 14 patients developed Lewy body dementia. One patient developed atypical Parkinsonism called MSA, multiple systems atrophy. 5 patients developed some cognitive decline. And overall, we saw that now whenever we see patients with REM behavior disorder, we should think that in 5 years' time, they'll have about 35% risk of developing some neurodegenerative disease. And in 10 years, they have a 75% risk of developing a neurodegenerative disorder. So how do we manage REM behavior disorders, and why do we manage it? Again, if it's just talking and it doesn't affect the patient's partner sleep, we probably don't want to intervene. However, if it becomes more active and more dangerous, then we should consider treatment. First of all, education about this disease to the patient is very important. And if there are any aggravators of REM behavior disorder, and if you can, you may want to discontinue antidepressants, so-called SSRIs, SNRIs, etc., but always talk to your doctor about that. If despite all this, you still have these episodes, you want to use a low-dose clonazepam or melatonin. Usually the first line is melatonin, because we don't want them to have some sleepiness the next day, and especially patients who have cognitive impairment, we want to start with melatonin. Sometimes if these episodes are very severe, we use both clonazepam and melatonin. Another important feature is, interestingly enough, a study came out a couple of years ago looking at the actual dream content. What is this? What are the dreams, and do they have any significance? What we did see is that there is a positive predictor of cognitive deterioration. The more we see negative emotions in dreams, the higher the chance that the patient, or the risk the patient has in developing some cognitive deterioration in the near future. Switching gears to another symptom that we see happening very commonly is excessive daytime sleepiness, where patients find themselves dozing off or sleeping during the day while being awake, or having trouble sleeping during the night. This again happens very frequently in patients with Parkinson's. Almost half of them have one of those two problems, or feeling very tired during the day and sleepy and not sleeping well at night. The reason why this is happening, of course, anyone who doesn't sleep well at night will be sleepy, but it's not just that simple. It's more complicated than this. The disease itself, Parkinson itself, impairs the arousal systems that we all normally have in place. It affects the circadian rhythm, that it's obviously affected with some other neurodegenerative mechanisms. Medications as well cause excessive daytime sleepiness, especially the dopamine agonists. Of course, not sleeping well at night, what we call fragmented sleep, is also affecting how people feel and how rested they feel during the day. And also some other sleep problems. If you have untreated sleep apnea, you may want to consider treating it, because that will develop and contribute excessive daytime sleepiness. We do see that patients feel tired the older they are, if they have some some dementia, some degree of dementia, and if they're on a lot of medications. So managing sleepiness, of course, we really emphasize the need of managing sleepiness and also helping patients not sleep during the day, and it's not always easy. We first have to look through the medication list. Is there anything we can eliminate or decrease or change to something else? If patients are on dopamine agonists, maybe we should decrease them or switch them to another medication, dopaminergic medication, that doesn't cause so much sleepiness. Try to keep the patients awake. I know this is very difficult. Patients, when they're inactive, when they're sitting watching TV or not exercising, or sitting in a quiet and a dark room, they will doze off. Always remember, after lunch, after a big meal, they will doze off. They'll feel very sleepy. This might be a time where you want to incorporate a light walk or going outside or doing some form of activity, so that you don't doze off. Light exposure is very, very big in keeping us awake. We want patients to be in very, very bright spaces, whether it's like turn on the lights, bright lights. And I know in Canada in the winter, you may not be having too much sunlight or the ability to go outside and walk, but at least keep your windows, your shades open, and make sure you're living in very bright rooms. If that's not enough, you might want to consider stimulants, modafinil, and amphetamines, if that is something that your doctor is willing to prescribe. And then for adequate sleep at night, we'll talk a little bit about how can we improve sleep at night. So that's coming in my next slides. Now, keep in mind, if you are feeling very sleepy, do not drive, because that will you have a high risk of traffic accidents. So insomnia is the actual term, but by American Academy of Sleep, is difficulty in initiating sleep or maintaining sleep, early morning awakenings, and these symptoms should be accompanied by daytime impairment relating to sleeping difficulties. This should be present for at least 3 times a week for at least 3 months. And I know patients, judging from my patients, they certainly have these symptoms. Now, how common is it in the Parkinson's population? It's actually quite common. So we are in general a sleep deprived nation. And in the general population, insomnia is anywhere between 6 to 30%. But in patients with Parkinson's, it's much higher. It's somewhere anywhere between 25 to 80%. So it's pretty high. And who gets insomnia from the patients with Parkinson's? Like I mentioned, a few of them don't. But overall, we see that patients in mild Parkinson's report about 25. So almost 1/3 report sleep onset and maintenance insomnia. So they have trouble falling asleep and maintaining their sleep. In moderate Parkinson's, about 40% have trouble maintaining their sleep and not so much falling asleep. And as you're listening to this, it probably relates to how your sleep is, where you are falling asleep very fast once your head hits the pillow. But then you might wake 2 to 3 hours later and keep on waking up for whatever reason that might be. So this is quite common. And it is difficulty maintaining sleep is one of the most common complaint or sleep complaint in patients with Parkinson's disease. So when I have a patient telling me that they're struggling to maintain their sleep, I don't just give them a sleep medication, because we have to identify what is it that prevents them from falling asleep. Women have higher risk of maintaining their sleep, but that doesn't mean that men don't struggle with it. So we usually go through this troubleshooting or checklist of what it is that that wakes patients up. Most of the times it's frequent urination. So they wake up and they need to go to the bathroom. Now, this is a little bit of a chicken and an egg situation where is it that you wake up and then you feel you need to go to the bathroom, or does the need to go to the bathroom wake you up? It can be either or none. Difficulty turning over in bed. A lot of the times patients are very stiff and slow and they can't turn over and change sides and positions in bed, and that leads to feeling uncomfortable, and that wakes them up. They have painful muscle cramps. Sometimes they have very bad nightmares, not REM behavior disorder, but nightmares. Some dystonia, cramping, again, that goes more or less this with the muscle cramps. Leg jerking can wake them up. Now, REM behavior disorder that I spoke to you earlier does not necessarily wake you up. Your spouse will, or your bed partner will. So if you're acting very violently, you might get a nudge, and that's how you wake up. So, but the symptoms per se don't wake you up. Unless, of course, you have an injury or fall out of bed, that will certainly wake you up. And there's another condition called periodic limb movements of sleep, where the patient keeps moving their limbs, their legs periodically, and that occasionally can wake you up as well. Now, this is the insomnia model, where we look at how we dissect when people can't sleep. So we're looking at their mood, if they're having any motor symptoms, dyskinesias, wearing off, cramps, slow movements, etc. If they have any pain, that's also very important. If some of the medications may affect sleep, if they have any restless leg syndrome, and that may lead to waking the patient up. And if they have some behaviors that may need to be changed or altered, such as napping during the day. Obviously, when you nap during the day, you will not be able to sleep very well. And I'll go through this really quickly because I know I'm probably running out of time. So motor symptoms, tremors, muscle stiffness, dystonia, these are some things that can wake you up at night. And there's a way of being able to treat this. So these are called, patients may have nocturnal motor fluctuations. So that's usually when patients are not taking their medications close to bedtime to cover them throughout the night. So we typically try to manage their dopaminergic medication. So we give them more long-acting dopaminergic medication at bedtime. A rotigotine patch, a long-acting dopamine agonist, can definitely help, and it also improves morning off times. The levodopa gel, the pump, can also help with sleep. Deep brain stimulation can also be very helpful with sleep maintenance. Now, with restless legs, that's something that can prevent patients from falling asleep. And restless legs is an urge to move your legs. It's usually an uncomfortable sensation. And when you move your legs, that uncomfortable sensation goes away. So I sometimes feel that it's misdiagnosed, because when you see that patients are moving their legs frequently out of nervousness, or maybe they have dyskinesias, that's not restless legs. You have to have an uncomfortable sensation that goes away with leg movement to have the proper diagnosis of restless leg syndrome. And this is what prevents you from falling asleep, because you feel very uncomfortable, you move your legs a little bit, it goes away, but then it keeps on coming back. It's worse at night and at rest. So we do see this symptom more frequently in patients with Parkinson's. Almost half the patients can have restless leg syndrome, as compared to controls, where it can be anywhere between 0 to 10%. It's a creepy, crawly, tingly, painful, or achy feeling that goes away again with movement. Usually affects both legs and starts at night. Patients have difficulty getting to sleep, have fewer hours of sleep, and in general, it affects their quality of sleep and duration of sleep and onset of sleep. Caffeine, alcohol, and several medications make these symptoms worse, so you might want to avoid these symptoms. Iron supplementation, if your ferritin, and this is something your doctor will check, if your ferritin is low, you want to supplement with iron. Ferritin is the storage of iron. And we treat with medications such as dopamine agonists, which coincidentally also help with symptoms of Parkinson's disease. So at night, we might want to dose with a patch that lasts throughout the night. And so it prevents you from being off and also helps with restless leg syndrome. Gabapentin also is helpful, pregabalin in very severe cases, opioids, although we don't obviously go there very frequently. Some patients will have trouble with urination. They wake up frequently to urinate, and they have this urgency. They have to go once they have the symptom. This is, again, something that we see commonly in patients with Parkinson's. A urological evaluation is necessary before we decide that this is not something like prostatatic bladder disorders, and it's just purely a symptom of Parkinson's disease. We do treat urinary urgency and frequency with medications such as oxybutynin, tolterodine, trospium, etc. And with that, the patient is able to sleep better because they no longer have that urge to wake up and urinate. If patients are struggling with mood disorders, if they have depression, anxiety, hallucinations, or psychosis, they will have trouble falling asleep or maintaining sleep. So one thing you want to consider is talk to your doctor to treat your anxiety or your depression. A few things on behaviors and how you can modify your behaviors to help with your sleep. Excessive napping during the day, we know that significantly weakens the sleep drive that you have at night. So in other words, you can't sleep very well or as deeply if you're napping 2 to 3 hours during the day. So try to avoid that. And I spoke earlier how that can happen, or we can do this and avoid napping. If you have anxiety and depression, we do know that you will be struggling with sleep. So try to treat your mood disorders. Anxiety leads to ruminations and thoughts. You might wake up in the middle of the night, start thinking about things, or not being able to fall asleep at night because you're worried. You're a worry being. And also it leads to dysfunctional sleep beliefs. If you have trouble sleeping or falling asleep, this becomes your norm, and that you feel that you are not able to fall asleep anymore. And it's something that propagates and really does not help you fall or stay asleep. Now, in terms of medication, some medication you're taking could be affecting your sleep. Some dopaminergic medication occasionally can lead to, again, daytime somnolence, sudden episodes of sleep, or even insomnia. So you might want to talk to your doctor about which ones are causing you to stay awake or causing you to feel tired and sleepy. Now, how do we treat insomnia? The best way is, and the initial step is to do what we call cognitive behavioral therapy or cognitive behavioral treatment. What this is sessions done by neuropsychologists who is trained for cognitive behavioral treatment for insomnia. That basically retrains your brain how to fall and stay asleep with different exercises, behaviors, meditation, etc. Light therapy is also very helpful. So if you feel tired during the day, you might want to have 1 hour of light exposure in the morning and afternoon to wake you up. And there's also these night lamp, the bright lamps or happy lamps that you might be familiar with, and you can use those on a cloudy and dark day. Exercise is very helpful, and it resets or normalizes your circadian clock, and you become more tired. So by the time evening comes or nighttime comes, you're more tired and fall asleep faster and stay asleep faster. Meditation, Tai Chi, low intensity physical activity can also be very helpful. And deep brain stimulation, although it's not the indication, we see that does help with sleep maintenance. So steps to have a better sleep hygiene, how to get to sleep. You always have to wake up at the same time and go to bed at the same time. Get plenty of natural light exposure. If not, you can use the lamps. Avoid stimulants, caffeine, and nicotine close to bedtime. Any thoughts or discussions that can cause anxiety, or watching TV and the news these days, you may want to avoid that, as this leads to anger, frustration, worry during bedtime. And you might want to institute a bedtime routine that is very relaxing, meditation. Make sure you use your bedroom only for sleeping and intimacy, and avoid daytime napping. Now, if you're in the middle of the night, you've woken up, or you're trying to fall asleep at any time in bed, and it's been 15 minutes or half an hour, just don't continue staying in bed. Get out of bed, change rooms, go somewhere, engage in a quiet activity, not with very bright lights, very dim lights, and then return to bed only if you are extremely sleepy. And how do we stay asleep? First of all, you want to minimize noise, light at bedtime throughout the night. And also, I'm going to add here pets. So you have pets that wake you up in the middle of the night, jump on your bed, want to be taken out very early. Try to avoid that. I know that's very hard, but keep that in mind. A lot of the times we've seen that pets can disrupt our sleep. Avoid exercise, heavy exercise within 6 hours of bedtime. Exercise wakes us up. It's great to exercise, but not during the evening or close to bedtime. So always keep that in mind. Any increase in temperature with exercise or ambient temperature will keep you awake or will prevent you from falling asleep. Avoid heavy late night meals. I'm sure everyone, probably most of you know to avoid that, because it causes a lot of discomfort. When you wake up in the middle of the night, don't look at the time. You're not going anywhere. You don't have an appointment at 3 a.m. in the morning. If anything, it will increase your anxiety on going back to sleep, because you'll start ruminating that, oh, I have to wake up in 3 hours. I'm not going to get a good night's sleep again. And this creates an anxiety over sleep. So try to don't look at the time. Don't look at the clock. It doesn't matter at that point. If you have troubles moving from side to side, you might want to consider using satin sheets, because you can glide easier and you can turn over quite with less effort, and that might help you with your discomfort. If you don't have satin sheets, you might want to try satin pajamas. They look nice too. And then if you are getting up in the middle of the night to go to the bathroom and you don't feel steady enough, or you feel unsteady or have had falls, you might want to consider having a commode placed next to the bedside, so as to prevent any injuries, as we hear that happens very frequently when they get up to go to the bathroom. Now, if none of this has helped, then we have medications that help us treat insomnia. These are some of the ones that have been used. Not all of them are recommended for ages over 65, but I'm going to go into more specifics. There's a strong recommendation against any of the what we call Z drugs, the Zopiclone, which is Lunesta. We don't use doxepin over 6 milligrams in patients who are over 65. We prefer to use melatonin formulations, longer acting melatonin. Suvorexant, called Belsomra, or Ramelteon, is also a medication that we like to try. Trazodone and diphenhydramine is not indicated. We don't like to use it. It causes a lot of sedation, drowsiness in the morning, so that's not something we recommend. And again, medications are not really given for a long time, just to help you get into the habit of falling asleep and staying asleep, and then we take them away after some time, a month or two. So this is overall the pathway that we go for insomnia. We look at the contributing factors, then we treat with cognitive behavioral therapy, some like exercise and light therapy. And then if none of this works, then we consider short or long-term therapy with sedative hypnotics. And that was all. I know I can be talking more and more about it, but I'll be happy to take any of your questions. And I'm going to, happy to hear if you have questions.
Dr. Vaou. We do have a couple questions. Oh, and more coming. So the first question from our audience, how would you manually track your sleep pattern?
Oh, that is a very good question. So manually track your sleep pattern. Well, there's different ways. You can do it with a diary. So if you wake up in the middle of the night, you just plot it down, or I wouldn't necessarily recommend that you do it during that time because that requires you turning on the light, waking up more. So this is not what we recommend. But if you wake up the next morning, just document when you woke up, etc. Or some of these wearables can be actually very good. For example, the Apple Watch can give you an estimate of how you're doing. That is also a good way to look at all the days or the nights that you have not slept and get an average with if you're making interventions to see if they're actually working or not.
We did have a question about the Apple Watch, so I do believe that you've answered that.
Okay.
Another question, how much melatonin do you recommend and what is the highest dose?
So depends what we're using it for. So for REM behavior disorder, I start at 6, at 10, and I go up to 10, up to 20, if depending on the efficacy. Now for sleep initiation, I really don't use it as much because I try other things. Again, cognitive behavioral therapy, behavior modification, all these things that we discussed. And in late stage, if it doesn't help, then I try medications. So one of my favorite is suvorexant, and it's very helpful for the patients as well. Now, if the patient has anxiety and they have ruminating thoughts, I will try an antidepressant or anti-anxiety medication.
I have a question from, could Dr. Vaou review the slide again about the connection between RBD and cognitive outcome? How the type of dreams you have can predict cognitive issues.
And so the studies show that if you have negative thoughts, negative dreams are really bad nightmares that they, and compared to what they were, let's say a few years ago, they seem to getting worse and worse and worse. They did see that this correlated with cognitive decline. So that is basically what that slide was illustrating.
If someone has been on trazodone for a few years and now has PD, would a switch to melatonin be a better option?
Well, it depends on what you're treating. If you're, well, I would assume trazodone was for sleep initiation or maintenance. I don't think that melatonin is going to make much of a difference. But it will help for REM behavior disorder. So again, it depends what you're treating. But if they were on trazodone for insomnia, I don't think that melatonin is going to make much of a difference.
If you have fractured sleep, if it has collectively total 6 or more hours, is that sufficient?
So ideally you want to aim at let's say 7 to 8 hours of sleep. If it's fragmented sleep, it depends how much fragmented it is, how fragmented it is. So I've had patients who tell me that I wake up 6 times a night. That's severe. If it's once or twice and you're able to go back to sleep, I want to say I'm being realistic. I want to say it's okay, but it's not perfect. If you're sleeping 6 hours, even if it was continuous, it's not enough. So we're looking at 7 hours. And we looked at longitudinally patients, not necessarily patients who have Parkinson's, but in general, in the general population, if you're sleeping for 6 hours or for 9 hours, you shouldn't be sleeping too little or too much. That leads eventually to increases your risk of developing some kind of dementia, some form of dementia, cognitive decline. So we really have to aim at 7 hours.
If I have tried melatonin in the past and I found that it was not effective, should I try it again?
Again, it depends on what are we treating? So if we're treating REM behavior disorder, maybe you should try a higher dose. If you tried it for sleep, to fall asleep and it didn't work, probably you should try something else.
Oh, very good information. I have one more question.
Mm-hmm.
Can REM sleep disorder cause people to be agitated, have delusions or hallucinations? And do they sometimes seem awake during these episodes?
All of the above, yes. So they can be yelling, screaming, acting out. They're living their dream, but for them, for the bystander, the observer, the sleep partner, it looks as if they're awake. They might be talking. They might be even answering questions. Most of the time, they may not. They won't make sense. But yes. Now, if they are, if they're in a dream that they're fighting with someone, or they will be fighting back. So yes, it can seem as if they're psychotic, but if they're asleep in their dream, it's REM behavior disorder. It's not psychosis. Psychosis is they have to be awake to be having a psychotic episode. So that's the difference.
Is THC an alternative for better sleep?
Not necessarily. This is not something we recommend.
What is a dopamine agonist, and
It's
why
one
not use trazodone?
So dopamine agonist, you will have to probably ask your doctor about it. It's a medication that we use for patients who have Parkinson's disease to treat their symptoms. And it also helps with restless leg syndrome. And trazodone, usually for sleep, causes some daytime sleepiness during the day and kind of have a hangover feeling when you wake up. Now, if it's working for you, just don't discontinue it. It's mostly for people who wake up and feel a little drowsy. I see that there's a question why THC would not be recommended. This is a whole different talk. It is legal in Canada. It's legal in the US. I'm not saying you should not take it, but there's many, it hasn't been well studied, and there are concerns about cognitive decline. So it's a whole topic. I don't want to get into it.
Would laughing in your sleep be a symptom of sleep disorder?
Laughing?
Yes.
Yes, it's REM behavior disorder.
And what are your comments in regards to computers or tablets at night?
Absolutely not. It's light emission. Light will wake you up. We can't hear you. You're muted, Charlene.
Sorry, that was me. I do not have any other questions in the chat. If anyone has another question. I got them. Oh.
So if there's no other question, is there another question?
Just a minute, I do have one more question.
Okay.
It's more like,
I can't hear you. You're muted.
okay. This one is asking about relaxation techniques and things that potentially would be helpful.
Mm-hmm. There's plenty. So there's meditations, there's white noise, there's an app called Calm. There's, I don't want to say go online and Google meditation techniques for sleep, but you can do that. There's also the cognitive behavioral therapist will recommend quite a few techniques. So there's many things to out there to help you with sleep.
I have another question. Does DBS affect sleep?
Yes, sorry, say that again.
Does DBS affect sleep?
It can help it. Yes, it can help it.
Are there other techniques to help not have to urinate at bedtime?
It could be some physical therapy for urination. Other than medication.
I've had the question again, if you could ask, or if someone has asked, if you could explain the action of a dopamine agonist medication.
That would be a little bit outside of the scope of this talk, but in brief, it's the dopamine agonist imitates dopamine in the brain and acts like dopamine. And if that is all the questions, unfortunately, I have to leave because I have to catch a flight. I thought the talk was until
Okay.
11.
We want to say thank you very much for your words of wisdom and all your knowledge that you've shared with us. It's very much appreciated. And thank you again.
Thank you so much. Thank you for all the amazing questions. And thank you for inviting me.